Over 100 individuals representing public, private, and nonprofit organizations took part in creating the National Forum. While one of the organization's key functions is building consensus, what makes the National Forum distinctive is that its strategies and initiatives are shaped and driven by consensus. Members help set the National Forum's agenda and guide its impact, and often achieve their own goals via collaborations begun at the National Forum. The Value and Access Collaborative, for example, arose from ideas and requests from members. Members can play vital roles in the new effort to broaden support for programs and policies that improve health equity. In this segment, National Forum members will share what they are doing along those lines.
Hi, I'm Marcus Plescia, the Vice Chair for the National Forum, and I'm pleased to come on now and help moderate the town hall session we're about to have. We're actually going to start off with the opportunity for a little bit of question and answer with our previous panelists and presenters. And we spend 10 to 15 minutes on that, and then we'll move on to what John just mentioned, this opportunity to really see what some people out in the field are doing and highlight some of that work. But I'd like to, we've pulled a few questions and comments from the chat, and I'd like to start off just, we've still got a couple of our presenters on, and I'd like to just pose a few of these questions to them. Several questions were focused on a theme that we've seen quite a bit of work going on in the field around health equity and social determinants of health. But much of it has been focused in other areas like cancer control and other compelling topics. And so the question a number of people asked is, how do we help, how can we help really shift some of this discussion and some of this emphasis onto risk factors for heart disease and stroke prevention, which are so important to our work at the National Forum. So let me just open that up and see if any of the presenters who are still on have any comments or thoughts about, you know, how to really move the bar with those important issues.
Marcus, maybe I can jump in here. Hi, Jay Bott, and with Deloitte, and appreciated the opportunity to be in conversation with my colleagues and others on the cost of health inequities. I think that what we saw was, heart disease, stroke, hypertension, hyperlipidemia are all contributing to the cost of health inequities, and that we've got to address the inequities there to have both on the upstream, and then I'll have a downstream impact on the progression of the chronic conditions and their outcomes. So in order to get to equitable outcomes, and we need to have that as a clear focus in addition to cancer, which is another area we looked at, as well as mental health.
Great, thank you, Dr. Bott. Any of the other speakers want to comment on that?
No, I think it was well said. Nothing to add.
Okay, well, let me move on to another question that we got from the audience. This one is, as we know, there's just been so much political discord in our society and as of late, and that discord really makes solving the health gap much harder. Any ideas about how to come at that? I mean, how can we make this issue, which is really important for everybody, less partisan and something that we can really unite behind? I know that's the question we all don't know the answer to, but any of the panelists have any thoughts at least about how we might make some inroads there?
Marcus, if you don't mind, I'll take a first shot at that. I think one of the key solutions is to remember that meaningful change begins locally, and that would lead to stimulating recurring and frequently focused local conversations about how to get to the better outcomes. It would require ceasing the focus on politics and focus more on policies that make a difference in our communities. I think if we can find a way to get those kinds of conversations occurring locally, then we can allow people to get in contact with their better angels and look beyond the immediate satisfaction of political gain. To me, that's the only solution that I could see to the problem we face there. And I'd love to hear what my colleagues have to say as well.
Great, thank you, Warren. Anybody else want to weigh in on that one?
Yeah, I would just echo Dr. Jones' comments and add that were well said. I would add to it that if you're a local government, city, state, county, if you're an employer, that point is exactly right. Meaningful change starts locally, but it starts with your own employees also, and those that serving. If you've got employees that you're engaged in around health benefits and wellness benefits, then you're in the health business. And it's important to the productivity, to their engagement, to retention and recruitment, and ensuring that their health is well supported. And that's why these interventions and the action is so important and matters.
Other comments?
Yeah, I think just important in order to step away from that political perspective to keep in mind that this is about basic humanity, right? This is about people and fairness, right? And we want to just make sure that we're providing resources and services that are fair for everyone, right? Even removing the word equity, sometimes they can be triggering. The reality is it's about what's fair, and keeping that in mind that in the wealthiest nation and the greatest nation on the planet, we should be able to provide baseline equitable healthcare outcomes for all of our citizens. And so that should be the goal. And for us to continue to be the greatest nation on the planet, right? That's extremely important.
Absolutely, no, that's a nice positive framing of it. I'm going to ask one more question, and then I'm going to move us into our presentations because I just remembered that our first presenter has a hard stop at 2:30. But there's one last question that we've gotten that kind of pulls things together. I mean, what further investments can we make in public health that'll help us reduce health equities, particularly around cardiovascular disease? Any thoughts on that? I mean, I know the panelists have hit on a number of these, but anything you want to pull out or really highlight here in the last question?
Maybe I'll start and say that I think addressing the drivers of health we know that if we don't do that, we're going to have inequitable and poor health outcomes, and it's everyone's collective effort. It's all stakeholders and partners doing that together, playing their role. The other thing I would say is health literacy. I think how language gets communicated in websites and benefits, in sharing with historically underserved, vulnerable, and marginalized populations is important. And understanding the cultural context in which they make decisions, understand health, and that kind of training. And I think as we do digital, as digital health grows, digital literacy and the use of technology in appropriate ways, addressing bias and some of those elements important.
And I'd like to steal Joshua's term of intentionality. If we don't drive the kinds of decisions, funding and policies that makes improving public health intentional, then we'll continue to fall short. Right now, it's kind of like what's left on the plate after everyone else has eaten. Okay, and we've got to change that. During your panel, Jay, folks asked about why some individuals were hesitant to support public health activities right now. It's because payers feel it doesn't happen on their watch. If they invest in public health, the benefits of that may not show off for 3 to 5 years. That means that it'll be insured by someone else and they won't yield the benefits. So what we've got to do is change the narrative, become intentional by having the impacts of public health, and make sure that it's first off the plate, not last off the plate. And Joshua, thanks for letting me steal your term.
No worries, no worries. I think the one thing that I would keep in mind is that the intersectionality, we touched on it a bit in our panel, right? We can't just talk about health outcomes without understanding how that intersects with wage inequality, right? We talk about the fact that 85% of chronic illness is directly related to diet, right? In many communities, they can't afford to eat healthy, right? And so what does that look like when we're talking about wages, when we're talking about housing, access, it's not a choice if you don't have an option, right? Or if you don't have means of transportation to get there, right? It's not a choice if you can't afford it. And so keeping that intersectionality in mind, we can't just talk about health outcomes in a silo. They're going to have to intersect with many other aspects that people are facing every single day.
Great. Well, thank you very much. If let's just hold tight for a minute. I wanted to go ahead and move us into the next part of our discussion, where we're going to hear from some people from the field. There she is. Okay, just wanted to make sure we could pull up some of our speakers. And I'm sorry to end the Q&A a little bit early, but I know that Alicia Justice has a hard stop at 2:30, and she was kind to come in and speak with us. And since I work very closely with her, I know she has some, I think, some really interesting work to share. So, and again, just a little bit of a cue up here. It's this part now of the agenda where we really want to spend some time hearing from the field. We've got about 8 agencies or individuals queued up and ready to give us a little bit of a synopsis of the work that they've been doing in the field to really try to implement some of what we've been hearing about. And I just wanted to clarify, please, others, as you're hearing this, if you have some things to add, we can queue you up through the chat or the Q&A, and we'll bring you on after we go through the first 8 presentations that we have. But let me go ahead and turn it over to Alicia, who is going to talk to you about some of the work that they've been doing around health equity and social determinants.
Hi, everyone, and thank you. Thank you so much for whoever finally got me in here. I don't know what was going on. But yes, I'm Alicia Justice. We've been working primarily with state public health agencies just to help support them in activating their health equity dollars out of the 02-21-2103 federal grant that all states received to help give them some resources to really focus on the health disparities that we saw that were just really exacerbated during the COVID-19 response, and really that continue to be really challenging. We have found that out of the work that we're doing with states, there is significant focus around engaging CHWs in a more sustainable way, which has a lot of thriving implications for how far we can really spread the work that we do around public health equity. There's also a lot of concerted attention of looking internally within state public health agencies and how can we really create a culture of equity in the way that we work, in the way that we design programs, in the way that we have policies to support our staff better to actually do health equity work. And then the other area that is getting a lot of attention and has a lot of implications that will likely not be surprising to any of you all is really around administering public health dollars in the most effective way to advance health equity. That's been both a source of, I guess I would describe it as revelation, but also a sore spot. While funding really opens up vast opportunities, what it doesn't do is it challenges public health to really have to reframe how we are motivated for building community-based trust that is not transactional. And so we're talking about how do we sustain the trust that we build within communities in between funding streams, and how do we approach and continue to engage community partners without the carrot of funding alone. And so funding can't really define the value of community partnerships. Funding can't determine if we're going to meet with a partner, or if we're going to have a phone call, or if we're going to just do a check-in and say, hey, how's it going? I know you all were working on XYZ. How did that go? Is there any way that we could, support you in the future? So coincidentally, even though the health equity funding that they have is very much time-based funding, the health equity funding actually calls us to be a little bit more authentic, strategic, and compassionate. All of this funding has, a project period end date, but that doesn't necessarily restrict us from thinking critically and thinking beyond this moment on how we can really profoundly, authentically, and compassionately sustain these partnerships because all of us know that the health disparities that were exacerbated during the pandemic and that continue to be so were not new. That was not new information to us. We were aware that a lot of these challenges had long existed, and the pandemic literally just put an even larger magnifying glass on those things. And so this opportunity is wonderful, and funding resources, they should be sustained. We should be able to rely on health equity dollars to support this work, but that's not the only thing that we should have to sort of rely on. We really got to bake in some of this non-transactional relationship-based work and really think strategically. The last thing that I'll say that has created a bit of a blind spot is the way in which we can think beyond the dollars while strategically planning for ways to really braid and blend funding streams across, different program areas, different divisions, even across different organizations. Because that blind spot has really illuminated the fact that we have a bit of an inability to plan based on current financial data, for example. This grant presents an opportunity for states to maybe build out a financial database that they could use for strategic planning, so they could really have some insight on, well, how much of our public health dollars are really going towards advancing health equity? And what does that investment mean? And how can we communicate that for more buy-in and for more sustained work that we do? And maybe we can utilize some of that data to help draw in different audiences and bring them into the fold with us to better understand, this is the investment place that we're at. This is what we've seen change as a result of that investment. And here's an opportunity where you can come in and partner. And so we really think that the funding opportunity that they've gotten may give them some ways in which state public health can build out some financial data systems to help with some future strategic planning. But again, it's a lot of relationship building. I think it's a lot of mental models going on within state public health, kind of maybe reevaluating some heart and head alignment and some paradigm shifts that are really going to have to take place of how we, value our community members beyond transactional funding alone, and really remain an authentic and a dependable partner within communities to continue to support them in advancing health equity. So I'll stop there, and I'll stay on as long as I can, but I may have to hop off quickly, but it was great to be gathered with you all.
Thank you, Alicia. It really is an exciting project that you're working on, and I'm so glad that you've been able to take the leadership on that. Next up, we have Mike Thompson, who is with the National Business Coalition on Health.
Thank you, Marcus. So I'm actually with the National Alliance of Healthcare Purchaser Coalitions. That's our current name. We used to be the National Business Coalition on Health, but we're the umbrella organization for employer coalitions across the country. And earlier Warren talked about, the equity agenda has to get real, has to get local. And then Jay talked about employers have to start with themselves through their benefits, through their overall organizations. We're the intersection of those two, employers and local. We have regional coalitions across the country with major private sector employers, public sector employers, and union groups as well. So very big constituency. The equity agenda for us has been a relatively new journey, and that we're just getting started. I think we're all just getting started, and I think we have to think with that mindset. This is a longer journey than a project. I think we started with a series of race, health, and equity town halls last year. And we have continued with a number of different things. We did a major project with the CDC, looking at how to engage employers, working with employers, engaging on social determinants in communities that are relevant for their employees. We learned a lot in that process, including how to navigate really different cultural perspectives on how to think about social determinants and specifically social needs What tends to be one of the key motivators for employers is to make it relevant to their employees. And oftentimes they discount that their employees have needs, and in fact, they can be quite pronounced, and certainly in pockets of their employees, it's very significant. But we've also learned and reinforced that equity doesn't start and end with social determinants of health. It certainly is inclusive of that. It isn't limited to low-income employees, although it's certainly an important component of that. It really is endemic to everything we are doing. So whether it's how we design programs, how we communicate programs, how we partner with others, how we engage with communities, how we engage with providers, health plans, and others. Employers are central to influencing the entire system. And if you look at other things that have been very successful within the employer community, things like quality, safety, even a culture of health, they have certain parameters where it is a core value within the organization, and it's endemic in everything they do. And I think that's part of the lessons we're learning here is we need to follow that same pathway of embedding equity as a value into what we do. And when we embed equity into the value of what we do, we really look internally about everything we do and have that as part of it. And then secondly, we start expecting that of the people who work with us, just like we do in quality, or we do in safety or health. We expect our suppliers similarly to be similarly committed. And somebody said we had a webinar just yesterday looking with 5 coalitions that have done great work to get started on the equity agenda, and what were their lessons learned. And one person said one of the most important lessons is that employers need to be asking the question of everybody that they work with, what are you doing about health equity? It's an open-ended question, but it sets a tone from the top of the food chain, if you will, that the people we're going to deal with are going to be committed in this area, and they're going to have a story. It may not all be the same story, and we may contribute in different ways, but we will be there. We just conducted a survey that looked at where employers are on their health equity journey, and it's not all employers that have gotten even started there, but a very significant part of them have started to engage outside their silos, engage across benefits, HR, DEI, and frankly, business leaders to understand collectively how they affect each other and how they can work better together and actually bring inputs into the processes as they move forward effectively together. A little lagging on that is measurement, actually using the data, examining differences, and taking responsibility for those differences. And then finally, lagging that is really accountability internally and accountability externally on that. But we see progress across the board, but it's going to take time to embed that in how we do things around here. And I do think it's going to be important. I heard the word intentionality. We use that word all the time. To embed equity means to be intentional about differences. It's to recognize that it is not enough to do the same thing for everybody. Equality is not the same thing as equity. Equality is, and we do hear that pushback. We provide the same benefits for everybody. We communicate the same way for everybody. Equity is not about equality. Equity is about creating equal outcomes, looking at variation, embracing variation, and using that as a guide point for where investment occurs to narrow variation. That's what you do in a quality organization. And that's what I think the leading employers are embracing and moving forward with. So we have a journey to go. I think it's thinking about equity being embedded in our inputs, so that, who's making the decisions in the organizations, who's involved to help us understand variations in need, engaging across lines that traditionally have been fairly solid, or walls have been fairly solid with DEI and other key community leaders and others to better understand what are the needs, what's missing, how are we not getting it right, and then being intentional on the outputs too. If we're doing storytelling, Are we inclusive in this storytelling? In the way we communicate, do we make sure, are we intentional about communicating in a way that is engaging all of our people? Interestingly, we had one coalition that presented yesterday who used as an example their work in the LGBTQ community. And they talked about their lessons learned. And we looked at them, we go, those same lessons learned apply to every underserved population. It's about inclusive, it's about feeling belonging, it's about understanding what their experiences are and then being intentional about that. So we're not talking about one subpopulation. There's a lot of subpopulations that belong in this equity equation. We are very early in our journey and we have learned a lot and we have a lot more to learn, but we are helping to facilitate change in the employer community, in the coalition world, and frankly, using those employers as key partners in communities across the country. So with that, I'll leave it there.
Great, thank you very much, Michael. Really great comments, and I like the sort of metaphor or comparison or embedding health equity into the quality improvement process, really. Next up, we have Dr. Jay Bott back again in a new role after being a presenter before to talk a little bit more about the Deloitte Center for Health Solutions and Health Equity Institute.
Thank you for having me back again, and appreciate this opportunity. So I just want to give a little bit more information about the Deloitte Health Equity Institute. Our mission is to advance health equity and make an impact that matters, and look at achieving health equity as an outcome. To do it, we're creating cross-sector collaborations and developing tools aimed at addressing the drivers of health, addressing racism and bias within and outside the health system, place-based inequities, and structural flaws in the health system. And we define health equity as the fair and just opportunity for everyone to have the highest potential for health and well-being. So our goal is to create exponential change that will lead to a world in which health isn't determined by race, gender, ability, status, or zip code. And we use particular levers to address those inextricably linked issues of racism and bias, drivers of health, and structural flaws in the health system. We activate key decision makers to accelerate change. We bring fragmented stakeholders together to advance equitable communities through place-based change, and driving health equity, innovation, and learning. And so some examples are, we've developed a playbook with the Black Directors Health Equity Agenda, as well as created a global health equity network with the World Economic Forum, with nearly 30 companies that are taking actions related to sustainability, climate, and equity. And then helping boards and leadership reflect the communities they serve, develop a health equity strategy, and act on it and measure it. Because you can't improve what you don't measure, and that when you have bold aims, those aims create systems, and then systems create results. Through equitable communities, through place-based change, we've done considerable work addressing COVID in Harlem and New York City, as well as in the Washington, D.C., Maryland area, working to also address maternal and child health through collaborations with March of Dimes on a maternity care deserts dashboard that's available publicly, as well as working with Morehouse on maternal health and workforce development. So really with the HBCUs, and then connecting that to our work in chronic disease with partners that are engaged in heart disease, stroke, and diabetes. And then building a community of social entrepreneurs with partners like New Profit, not-for-profit that's creating a community and supporting social entrepreneurs that are advancing health equity related efforts. And mental health is another area that we are working in with a number of other partners, both the Latino, Black and Brown communities, as well as rural communities, and with LGBTQIA plus communities as well around healthcare needs that they have. So really excited about our work. Our work is for the public good, and it's available to everyone. Our research reports, our data dashboards and tools, as well as learnings from our community collaborators. And so I encourage you to go to the Deloitte Health Equity website to access that. And we look to work with collaborators in creative ways, and we can drive philanthropic investment, pro bono services, work together on creating knowledge and evidence, analytics support, as well as coalition funding around issues that we prioritize. And we're working to finish up some work on COVID-19 and long COVID, but working on maternal health, women and children's health, and chronic disease, with drivers of health and workforce development kind of integrated through those issues. So thanks so much for this opportunity, and it's just an honor to collaborate and work with the National Forum and they're doing just tremendous work through the initiatives in moving communities to equitable future of health. So glad to serve and collaborate.
Well, thanks very much, Dr. Bott, for this and for your previous presentation. And Deloitte, you are certainly doing some great work in this area, and we appreciate that. Next up, we have Melanie Truehills from Stop AFib.
Thank you, Doctor. Thank you, Marcus, and thank you to the National Forum for the opportunity to share. And this has been a great program so far. I'm Melanie Truehills. I'm an atrial fibrillation patient who's been AFib-free for more than 17 years. I founded stopafib.org, which is an AFib patient advocacy organization to support those living with AFib. Health equity has been embedded in everything we've done since our beginning in 2007. And from very early on, learning from Dr. Ferdinand and from Dr. Yancey, we started highlighting and focusing on the African-American conundrum in AFib, where Blacks were not being diagnosed with AFib at the rates that would be expected based on their comorbidities and their likelihood of having AFib. And we believe that some of it is likely that they've been dying from strokes before even getting diagnosed with AFib. And through the National Forum, we also met and started working with Dr. Virginia Howard of the REGARD study and have amplified their findings with Blacks in the stroke belt. We've worked to ensure that African Americans and Hispanics and other groups are involved in everything we do, and we emphasize health inequities in media interviews, as well as working on guidelines, research study steering committees, coalitions, and think tanks. And I've been involved in the social determinants of health work of the National Heart, Lung, and Blood Institute Atrial Fibrillation Working Group. With that said, we're launching an advocate training program in January and are building health equity modules into that training. And we're focused on finding a diverse cadre of advocates to help us reshape the AFib landscape and reshape how we get care for AFib. We're also planning dedicated pilot projects to address health equities in 2023. And as a small organization of just 3 people, our work with other organizations such as the American Heart Association has helped us to have an outsized impact in the AFib space. So if AFib is an area that's a priority with you or your organization, we invite you to engage with us and to help us further health equity in the AFib space. So thank you for the opportunity to share.
Thank you very much. A very, very important area that I think really hasn't gotten enough attention in the past. Well, I think I see Brian, so I'm going to bump back to Brian Hart with the National Lipid Association.
Thanks, Dr. Plesha. Great to see you.
Brian.
And thanks to the National Forum for having me today. I'm Brian Hart. I'm the Executive Director of the National Lipid Association. For those of you who don't know, we are also 20 years old this year, and we're a clinical organization, a clinical membership organization, focusing on education and adding to the scientific space for cholesterol, triglycerides, and related lipid disorders. As the NLA is new, equity is fairly new to our organization. Our last president, Dr. Joe Cecine from University of Colorado, prioritized this explicitly as one of his priorities during his term as president. Our question to ourselves was, are we really able to meet people where they are, meet patients where they are? Looking internally at our organization, in fact, we created a diversity, equity, inclusion committee. We started with a review of our members. What does our membership look like? We are multidisciplinary, but is it truly multidisciplinary? we want to be where patients are, but are we where patients are? Are we exclusively at the universities and medical centers in major areas, or are we meeting patients where they are? Can we actually do this? In our case in particular, where are lipid specialists and where are they not? How can we help bring specialists to improve health equity? How can we educate more people, get more people certified as lipid specialists, and bring more to the community so there are more lipid specialists in more areas to improve health equity? We looked at our leadership. Does our leadership represent what we're looking to do? Does our leadership represent our ability to meet the patient where they are? And then since we're a smaller organization versus some of the larger ones, who are we partnering with? The NLA proudly partners. We're a grateful partner of the National Forum, the Value and Access Coalition. But in order to get to where we need to be, are we partnering with the right groups? And from this sort of audit of ourselves, we recognized there was an opportunity to improve. We could improve our membership. We could improve the availability of lipid specialists, ensure that health equity is part of our outputs, whether that is in our 3 meetings per year, in our scientific statements, in our coursework, in our certification exams, and provide training, both training internally to our leadership. We're in the process of developing an implicit bias training for our leadership and for those who select our leadership. We're in the process of building out our education, our self-assessment, our scientific statements to be inclusive of health equity needs. And then finally, as Dr. Bott provided earlier, the ability to measure it. Are we able to measure what we're trying to do? I think one of the things that I'm most proud of that we're really trying to put forth to improve health equity is the development of scholarship programming. Again, in our clinical space, how can we bring education on lipids, cholesterol, triglycerides to this problem, be inclusive of health equity, and then get it beyond our borders, beyond ourself? And so I thank you from the National Forum for the opportunity to share this. And this has been a great meeting. Thank you.
Thanks a lot, Brian. Really appreciate it. I'm very pleased to hand things over to Janet Wright with the Centers for Disease Control Division of Heart Disease and Stroke Prevention. Janet.
Thank you so much, Dr. Flesha. And I too want to thank the organizers for this meeting. I've really enjoyed the speakers, the discussion, and I have learned a lot. I was asked to share with you all where we are at CDC in terms of health equity. And unlike a lot of reports that I give, I only have good news to share. Dr. Walensky, from I think day one, set the tone and set in action a number of activities to prioritize health equity, both in the work that CDC does and here at home in terms of our equity, inclusion, accessibility approaches to recruiting and retaining a diverse and representative workforce. So in the very beginning, Dr. Walensky set in place what is called CORE here at CDC, and it is an acronym. The C stands for Cultivating Comprehensive Health Equity Science. O stands for Optimizing Interventions. R is for Reinforcing and Expanding a robust workforce. And then the last one is about improving the capacity and the diversity of that workforce. So again, what I want to emphasize is not only a framework in place, but deliberate and intentional actions to support the execution of that framework. The establishment of the core sort of principles gave rise to a charge to each of the divisions across CDC to develop at least one or more core health equity goals. I am delighted to share with you that for the Division for Heart Disease and Stroke Prevention, our 2 core health equity goals are improving hypertension control among African American adults by 5% in the programs that we support by the end of 2024. The second core health equity goal is to improve our surveillance systems, improve and influence the surveillance systems that we have access to to better identify the drivers of health disparities. We know that as we improve those surveillance systems and embed them with the capacity to identify those drivers, then we can start to tackle the drivers. So our division has committed full force to achieving those two goals by the end of 2024. I want to spend just another 30 seconds on other aspects of work in the division, and that is the establishment of a DEIA council. We have that in preparation and hope to launch it soon. That will help us put processes in place to ensure that, again, we are creating a workforce that is representative of the people that we serve. Lastly, I'll say and applaud our Health Equity Committee that has been in place now for, I think it's been a little bit more than a year, and has generated a set of principles and themes that are infused not just through the core health equity goals, but really across the entire work of the division. And it does not, incorporation of those principles does not have a 2024 deadline. That content is something that we work on every day to get embedded permanently in the framework, really in the DNA of the work that we're doing. So it sounds great. I think for me, I want to begin to see the results of these prioritizations that we've made, both in our division and throughout the agency. But I'm very hopeful that over time, we will evolve into a more equitable agency, and that will be reflected in our work. Thank you, Marcus.
Thank you very much, Shannon, and happy birthday.
Thank you.
Next up, we have John Kennedy from the American Medical Group Association.
Thank you very much. It's really my honor to follow Janet Wright and the CDC, and I've enjoyed this wonderful forum today. My name is John Kennedy. I'm Chief Medical Officer at the American Medical Group Association and President of AMGA's Foundation. Now, AMGA is a trade association that serves America's high-performing health systems and medical groups, and collectively, we care for about 1 in 3 American lives. So I'm very pleased to announce that in January of 2023, we're going to be launching a best practices collaborative around ASCVD. And we'll be having 15 of our AMGA members from medical groups and IDNs from across the country working to identify their population of patients with ASCVD that are at risk of secondary outcomes and complications. Now, picking up on that panel discussion from this morning, some of these are anchor organizations such as Ochsner Health System in Louisiana or UCSD in Southern California, but it's also a mix of community-based organizations like Bandera Health, which is an FQHC in San Antonio, or Hattiesburg Clinic that serves rural Mississippi. And so these groups are going to be identifying which of their ASCVD patients have suboptimal LDL control based on national guidelines. And then they're going to be implementing strategies over the course of the next 12 to 18 months to really close those care gaps based on evidence-based guidelines. And what's really exciting for this group is that each of these groups is going to be focusing on a health equity project. So they'll be sub-segmenting their data based on age, race, ethnicity, and gender. And they're going to identify what we call a health equity care gap. And then AMGA is going to provide the resources such as monthly webinars, a community listserv. We're going to have coaching with national advisors. And we're going to be using our population health nurse to teach quality improvement metrics. And then there's going to be networking opportunities with best practice sharing at in-person meetings, as well as virtually. We'll have monthly webinars for education for the providers as well. And all of this is going to be supported by data with quarterly benchmarking reports from our AMGA analytics team. So I'm really hopeful that we'll be able to come back in about a year from now and report on our progress to the National Forum on the prevalence of ASCVD, statin use, whether they're using the high dose recommended statins, as well as what % of their population are really getting their LDL to goal. So thank you again for the opportunity to join, and I've learned a lot today.
Thank you very much, John. Really appreciate you coming on. Oh, here we go. Steve Sidney. I understand you'd like to make a remark or ask a question.
Hi, I'm Steve Sidney from Kaiser Permanente, Northern California. Many of you know me in my role on the National Forum as Chief Scientific Advisor and authoring the annual signature reports. I could talk about Kaiser Permanente at length, which has been doing a huge amount of work in this arena. But I actually wanted to almost put in a plug on the report I'm working on for this year, and to point out an important area, not what I'm doing in it, other than learning about it and writing about it. But it's about cardiovascular health in pregnant women. There's about 3.6 million live births a year. And there is a lot of literature out on adverse pregnancy outcomes that occur later in pregnancy. In about roughly about 20% of pregnant women, about 2/3 of them at least seem to be cardiovascular in nature, not including the most dreaded ones, which would be maternal death, which is increasing at a rapid rate. And is probably about 25% cardiovascular. But things that more commonly occur, like hypertensive disorders, including preeclampsia and gestational diabetes, which puts a person at future cardiovascular risk, that occur in probably about 2/3 of those outcomes. And not only that, but maternal health as measured during pregnancy has been shown to be associated with the cardiovascular health of children, in particular a study looking at 10 to 14-year-olds showing a direct relationship between the cardiovascular health of the pregnant mother and the cardiovascular health of the child. And this goes to saying that we need to recognize, I think many, if not all of us do, that cardiovascular health and resulting cardiovascular disease is a lifelong issue, begins at least at the beginning of life. And as we see from the work I was just discussing with you, it begins before the child's ever born. I want to applaud all efforts to address this issue. And I think it's a hugely important one, because by the time we get to be adults, some of the damage and some of the preventability is already in many people somewhat compromised. Thank you.
Yes, thank you. I'm really glad that you brought up those specific issues in that population. I'm going to go back to Janet Wright, who had some further comments for us.
Thank you, Marcus. And I was standing and doing the wave over the Steve Sidney report. Dr. Sidney, really great to see you and to know that you're at work on such an important and hopefully action generating paper. I just want to say, in view of the fact that we are all in this together, and this is the National Forum is the place where we come to share and exchange. I had the benefit yesterday of sitting in this Scientific Advisory Coordinating Council for the American Heart Association, and not seeing Juliana on here, I just want to say, sitting with, these are the scientists, the clinicians, the academic researchers that meet on an ongoing basis and help steer the science ship for AHA. Everything I heard in 6 hours was rooted in and devoted to improving health equity. Remarkable infusion of health equity principles and actions and metrics in all the discussions of the day. So it gave me a great deal of hope and got me really excited about the work. So I want to applaud AHA for their focus. Over.
Great, thank you, Janet. And we are coming up towards the end of the session, so I'm going to go ahead and hand things back to John Clymer to close us out. Thank you.